So we have now, we're going to look at application of AI in clinical setting. And I know that Dr. Osric is an assistant professor of obstetric gynecology, is based in Qatar, in Doha. He's going to focus on looking at whether should AI be embedded in frontline clinical decision making. Again, another governance angle, but they are really, absolutely vital for you, the clinicians here. So Professor Osric, Navti, for those who might have just coming in, Osric, myself, and Professor Kunje, we run the international affairs at CamDocUK. And Osric is based, he used to be here in Leicester, and then he's moved to Qatar, in Doha. Osric, you've got the microphone.
So thank you very much. It's wonderful to be back. I think it's almost 10 years since I was last at CamDocUK. So the family has grown. There's a lot of much younger people and much more beautiful people here now. So thank you all for coming. Obviously, we have 30 minutes, so it's a bit of a challenge to sort of try and cover all that we need to cover. But it's a discussion that we should really be having. And so my talk is really going to try and address some of the current applications of AI in clinical practice, discuss the risks and benefits, and sort of talk about some of the things and challenges that we should be prepared for in terms of AI. So let's see how this works. Oh, sorry. Go back. Okay, so this is the first slide. So if you scan that, and I want you to sort of come up with, let's see what words come up to mind when you think about AI. We'll give a few more seconds. Okay. So it's a range of stuff. It's a mixture of feelings, right? There's a lot of fear, but there's also promise. And that really is what AI is all about. And hopefully at the end of today, we'll be able to sort of come up with making it less scary. So next one, okay? What best describes your current status on AI in clinical practice? Okay. So again, we're kind of split down the middle in terms of enthusiastic and cautious. So moving on. So, yeah. The next. Yeah, that one. Okay. So this is kind of stuff, you know, when you hear about AI, the kind of headlines that we see, okay? Would AI replace doctors? And this is something from yesterday. I was going through preparing the slides, and this statement to the right came up. AI made the doctors worse. You might be next, okay? There's a bit of context here, okay? The real danger, and what they did in this study, which is published in the Lancet Gastroenterology, was look at pre and post AI application. So AI was deployed, the doctors were using it. Obviously, it reduced it improved the accuracy rate. But then someone thought, okay, what if we then take away this tool and see how the doctors perform compared to before they started using AI? And the doctors got worse. Okay, so therein it's a bit of caution there. So AI improved our ability to make diagnosis, but when we now took away that tool because it flipped, for whatever reason, it wasn't working, and these are some of the challenges about AI. Who controls it? Whose hands is it in? And who's feeding the stuff that we're using that is in AI? These are all things that we really need to think about. A lot of headlines here about AI. It's a whole range, some quite scary, but also some quite promising in terms of what AI can do. I mean, there's times when AI has been, you know, But if you listen to what was the name of your Lixia? We talk about lack of empathy. Did Lixia not sound empathetic? Okay, so again, the whole empathy thing is overblown. Alexa and all these things can be empathetic. They learn it quite quickly. And I've seen the range of doctors that I wouldn't consider empathetic. Okay, I think having worked in multiple regions of the world, I mean, some of it may be cultural, but there's a sort of language model that some of our colleagues that come from specific parts of the world use that to us would definitely not be described as empathetic from a Western concept mindset. But maybe in their countries, that's empathetic. Okay, it's very matter of fact and blunt. Sammy, we need to go to the next slide. So would you trust AI to make or contribute to your own healthcare decisions? Hands up, who would? To contribute. Who would be happy for AI to help in? Okay. So quite a lot of us are happy for AI to make those decisions. We'll go on now. And then I bring this up because this is quite relevant data in regards to how we as doctors feel about AI. Okay, this is from the American Medical Association. It's a kind of a busy slide, but in essence, most doctors, 80% currently use AI. Most are excited about AI. Most feel that AI continues to trend positively and it provides an advantage in the ability to care for patients. Less than half are excited and equally concerned and excited about AI. I think that's what we got from the poll in the room here as well. Doctors felt that patients used AI, but they were concerned about which ones patients were using and how reliable they were. And I'll put a slide at the end, which I think is quite useful from the American Medical Association. And one of the challenges was about the training, or if we received any training at all on using AI. So those of us that are enthusiastic and early adapters basically train ourselves, right? Has anyone here actually sat down in a course that was to teach you about how to use AI? Okay, well, you're hard of the group. Okay, so you know, he's the AI guy. But as physicians in big hospital organizations, virtually none of us have had any training in the use of AI. So that's the kind of stuff that you're talking about. Who thinks by 2035 AI will deliver safer clinical decisions than most healthcare professionals? So a few people, but certainly not the majority of us, okay? Now, the reason for this is that if we look at absolute data and evidence, so this is a large systematic review, and we consider this the gold standard in terms of research. These large language models have demonstrated diagnostic capabilities and potential for application across various clinical scenarios. Accuracy may fall short of clinical professionals, and it should be used cautiously. But the trend is definitely in the direction of massive potential. Okay, so the data and the evidence is building. However, when you then ask patients themselves in terms of patients' attitudes towards the AI doctor, so this is patients' attitudes towards the doctor that is using AI, patients across the board, when you look at reliability, empathy, comprehensibility, and willingness to follow advice, they still prefer the human doctor, okay? At best, AI is equivalent to the human doctor and AI. So at the moment, our jobs are still relatively okay. For now. Okay? So we're going to have a bit of a discussion. I'm going to split the room into theoretical half. This side, I'm going to ask you guys to come up with things for, okay? And this side to come up with things why you think we should be against this, okay? So AI would become the first reviewer of diagnostic information. You guys are for. So I'm waiting for ideas. Speed, okay? Anything else? Efficiency. This side against? Volume. So speed, volume, efficiency, accuracy maybe. What's against this concept? What are the dangers? Descaling, okay. Anything else? Okay, hallucinations. But what also feeds into the hallucination side of things? Yeah, okay. Data. Where is this data from? Who's represented in this data? Okay? And this is a real problem. I'll give you a little bit of an anecdote. A few years ago, I had my first debate about AI and clinical practice with one of my colleagues at a conference. And when I put up a question about something as simple as this, give me a photo of black doctors treating poor white kids. Black doctors treating poor white kids. AI said that didn't exist. Okay? But if you think about it, are you surprised? Okay? So it was about what AI is used to. Okay? So it couldn't figure this one out. Didn't make sense. Doesn't happen. But that's the reality of it. So we'll just move on. So, we talked about faster diagnosis, consistent, reduced variability, earlier detection. The problem, of course, is bias, missed contextual clues. That is where the experience comes in of a clinician, hallucinations, and ultimately, who's accountable if AI makes a mistake? And this is a real challenge. Okay, if as a doctor you're using AI and you come up with the wrong diagnosis, is it AI that messed up or is it you that messed up? Well, so both of you messed up, but AI can't be taken anywhere to court, right? For now. Okay, so a bit of data out there in terms of AI and its use in absolute new better clinical practice. AI in medical imaging, you kind of see how accurate it is, okay? 95% accurate. So we're talking about mammograms, we're talking about chest x-rays, and the direct implication of this is that if you have a busy hospital that Johnny is trying to run, and he's having to employ staff, he thinks, well, I've got this tool that can reduce and speed up the reading of x-rays. Because one of the frustrations in NHS, I mean, my wife had an MRI recently and the results took, 48 hours, 72 hours to be reported. And this is with connections, okay, in-house. This is with connections in-house, okay? So the reality, and this was it's an emergency situation. So what AI does and what is employed to do is to make this much quicker. So AI would be able to say, this series is normal, I can report this. The ones that are challenging or they need a human input will be the ones that will be triaged to the doctors to do. So it improves efficiency. Pathology is obviously well applied to AI use because AI is really based on pattern recognition. The large language models, you feed thousands and thousands of images, and then it recognizes that that's an abnormal cell. That's what I should be calling. And so it's seen thousands, whereas the normal average, slide reader will see a few thousand. The AI model has seen millions. It's been trained on millions. So you can see the difference. Dermatology, very good at also. But then when you talked about, clinical symptom checkers that are public available, therein lies the problem. Because part of it is probably what language you use to input, and Theodore brought that up in terms of language as a key factor in terms of what questions and what prompts you use. And again, we have time, I'll put that slide up, which is from the American Medical Association, which is helpful. Okay, so this is a bit of thinking here, okay? So the real discussion really is about the efficiency of AI, but also about the humanity of humans as the primary givers of healthcare. How do you balance that out? Which is more important? Is one more important? Or both important? Okay? But if you are a manager, if you're in Johnny's chair and he's having to run the department, what's he looking at? Okay, so the perspectives are completely different. And they don't necessarily marry. That's why when they move over to the dark side as managers in the NHS, we sometimes wonder what happened to our colleagues, right? But their mindset changes. Their sort of reasoning and what they are meant to do is it changes completely. And I always wonder how, as senior clinicians would become managers and leaders in organizations, how you merge the two and keep that communication between the two sides of your experience. It's a challenge because obviously one begins to drive the other, okay? So risks. This is a real challenge and we need to address this as well. These are all sort of screenshots from various people that, obviously we're very concerned about AI and raised the alarm bells. Now, Mo Gaudat, anyone know Mo Gaudat? This guy on this video? A few people? I'll share, I actually came across Mo Gaudat and I've listened to him in Doha speak, but he's an interesting guy because he was one of the founders of Google X in terms of technology, and he was at the infant stage of the whole development of AI. And he knows the capacity of what this stuff can do, and they come from a point of this stuff can get out of control, and if it does, we are doomed because we can't control it. And so we need to put the safeguards in place now. But he also has a more interesting story because he flipped from technology, and he has a story about losing his son to surgery, which was routine surgery, so to speak. And then he wrote a book about happiness. And that became a bestseller. And basically that became his main job, about being happy in your life. But it's quite interesting as well. If you've not listened to him, he's riveting, and you should listen to him. And basically, the people that built this stuff are telling us to slow down, okay? But the problem is the technology is so fast that we are not able to keep up with it. And the governance side of it and the law side of it is struggling to catch up. Okay? So this is the risk side of it, okay? AI systems depend on data. As I said, where does that data come from? Is it complete? Is it incomplete? How much African data do you think is in those things? For underrepresented groups, this is a real challenge because then it leads to incorrect recommendations and diagnosis and treatments. And that leads to disparity in care, which is very clearly been demonstrated. Okay, when you use some of these algorithms in US hospitals, outcomes were much poorer for minority groups. Okay, because these were not the people that were fed into the system. So we really need to be careful and to be aware of these limitations. So how do we develop that responsible partnership? Okay, there is attempts to do this. WHO, only this week, I think there was the first high-level UN meeting on AI and governance. And interestingly, they avoided coming up with recommendations, but they opened the floor for the discussion. I think next month there's a meeting in Geneva that goes on to discuss it with an objective to try and form a framework for how we deal with AI going forward across the board. But part of the challenge is, as I mentioned in passing, is about, if you think about AI at the moment, there's two major countries, China and the US, okay? And now actually in those two countries, if you look at who actually owns the stuff, it's actually a handful of people and companies, okay? Now that's quite dangerous because these people can basically hold the rest of the world to ransom, okay? The wealthy don't have any concept for the limitations of wealth, as we can see very clearly with how they influence politics and everything else that's going on in our world today. So these are all real things that we need to discuss. I'm just going to highlight. So the future. How do we see the best way to proceed with this AI thing? So we're going to have a bit of a discussion again here. And these are the things that I want you to sort of talk about. So someone take the workforce. How do you see how, if we're going to use AI, the ideal setup, how do we think we should build those factors into it? I'm sure we have ideas.
From data point of view, it's feeding in wait for the microphone. As we keep seeing, the influence of bias and the absence of information on represented groups is a big challenge to the accuracy and efficiency of the AI. So getting better quality data, non-biased data, more representative data would be one of the things, to keep the AI to more efficient.
And how do we do that in terms of the underrepresented groups? This is a challenge across the board, right? We've been saying this for decades. But it's about involving our communities in research. There's someone at the back there.
Yeah, I feel the problem is even more deep when it comes to applying AI in low resource countries like Cameroon, because it's not just about the patients, but about the existing systems in place. Are we going to scrape them out and westernize them? Because the patient data in itself will not correspond to the treatments that are coming from a different environment. So we should be careful from that perspective.
Yeah.
Yeah.
So local, another point here. Local data to drive local solutions. And that's really important.
I think the best way to approach this is to contextualize, where we design and build different models based on different use cases. He mentioned the case of Cameroon. We should have a model that focuses on that particular case for Cameroon, and so that AI doesn't become a blanket kind of implementation. Not all models are the same.
Yeah. And that's where people like you come into the equation, right?
Hi, thank you very much for your lovely presentation. I just want to say, in terms of the workforce and the use of AI, I would like to think that at some point we could consider stratifying the use of AI based on the cadre of the healthcare personnel. Because I've experienced situations where, let's say, a junior doctor gives data from a patient to AI, and the output they get is completely different if it was a consultant who was putting in that data, because the junior doctor didn't take the complete context of the patient information, and it drives you on a completely different tangent, and you could give a very dangerous and wrong treatment to a patient based on the information you put in. So I think at some point we can think about different cadres of healthcare personnel and their use of AI. And
so the point you're making is not that they've put exactly the same prompts and questions into AI. Is that your clinical experience means that you know what things you are concerned about as a more senior clinician, and you ask those questions a bit more directly. And yes, and that's why we talked about the importance really of being trained in using this stuff. I'm going to come to spend some time on some of the options that are available. We'll come to that and spend a bit more time for us as medics, okay? So currently, this is where AI is really being used across in clinical practice. Clinical support, clinical decision support. The old days, up to date, was probably your first one. There was Medscape. These were all sort of the initial first ones that were internet-based, web-based things that we used. Then we know about diagnostic imaging that we've talked about now. Documentation and scribing, I know many trusts now use this in terms of your clinic, and then it just scribes up for the GP and makes up your medical notes as you go along. It's really important for triaging, as I said, in terms of reports from radiology and pathology. So the ones that are straightforward and very clearly normal, then they reported straight away by the AI model. And it's the ones that you have issues with that you then get a second look by a human, okay? Medicine optimization, if you use electronic medical records and you're doing your prescriptions, it will come up and say, prompt you and say, this patient is on this, is there a link with this other medication? So it makes you remember that you need to check, okay? But it's only as good as the information you've put in. So if the patient hasn't told you they're taking X, Y, Z, then you still have the issue. So your history taking and your medical history is even more important still. Drug discovery. Genetics is fascinating. I mean, I'm in fetal medicine, and I think the world of genetics is one of the things where AI comes into its own. When I was training, doing my subspecialty training, I spent some time in clinical genetics. I used to call those guys like the Hercule Poirot of medicine. You get a baby comes into the room and they're beginning to think the ears look a bit funny, or the eyes look a bit funny. You know, they're like, you're coming in, they're already sort of looking at you and they can see stuff that Johnny and I can't see. But these guys are really good. And obviously there's 1,000 genetic syndromes and things that you can come up with. It's impossible to know all of those, right? But then with AI and with all these large language models, if I can pick up these features and I put them in, the AI will say, okay, if you have low set ears, white, palpebral features, flat forehead. Okay, this could be Down syndrome, for example. That's kind of what it will, that's the difference it makes. But also the depth of the things that we can pick up. I mean, we explain to patients this way. In the past, when we were doing prenatal testing and we talked about Down syndrome or whatever, it's like you're looking at the satellite in space and you're looking at Earth, okay? You can see from that distance. But what the technology now does is that if you have a textbook on Earth, it can open to page 44 and tell you what's on line 7. This is the sort of detail that you can see. No longer just look at the country from space, but you can look at the country, a town, a book in somebody's house, and tell you what's on page 7 in that book. Amazing, okay? But it also throws off stuff that we don't know about, so we cause a lot of anxiety for it. I put this in because this is my real life, okay? So this is an AI helper. So if I'm scanning, okay, with the tool that's on the machine, if I get certain images, it selects that profile, it labels them, and it just stores the image. And so it comes out green, 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 and if there's something that I missed, then it will be the one that is missing, and so my workflow pattern is improved significantly, okay? So you're scanning, you get the view, it just captures it, it labels it, and then you move on to the next one. Okay, so I hope this will be useful for people because this is really important. So the most important one was open evidence, which was the first really useful one, but it's been blocked now because it's US based. So anyone use open evidence here? Really? Does anyone use any of these things? Yes. Which one? BMJ. MedWise. BMJ. Okay, BMJ. So there's like a few people. This is my life. I'm like on this stuff every day. Okay? That's why you're here. Okay. But liveevidence.com is a recent one I found. It's very obs and gynae specific, and it's very, it's really useful as well. So MedWise is really good. I think people should download the app and play with it, but you need to know what prompts to use because it's really, really, it's fascinating if you put the history. Be very careful when you're using these things not to put patient identifiers. This is really important because it stores this information. So please, you're going to anonymize the patients, okay? Say you're a 45-year-old African background, blah, 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 and no identifiers. So we've talked about this. I think multiple speakers have highlighted the importance and the irreplaceable role of humans. We provide more patient-centered care. Our expertise counts for something, years and years of practice. There's things that you get with intuition and experience, and also critical thinking is important. But also you make decisions from an ethical perspective as well, which AI at the moment isn't so good at. But as we keep saying, this stuff is learning so fast that it will get there, without doubt. It's going to get there. But we as humans just need to keep ahead of the game, okay? So final take-home messages. We can clearly see that AI can improve efficiency and support decision-making, but AI can also introduce bias, errors, and accountability challenges. Human judgment remains essential, and the future is definitely that collaboration between the clinician and the AI, not a replacement, which is what we all feared would happen. And this statement is been well circulated, and we all know about it. So the physician that's going to survive is the one that uses AI. The one that refuses to use AI is going to become irrelevant. So learn how to use this tool. It all improves the practice that we get. And this is interesting. I found this a few days ago. It's from the American Medical Association for the public. It talks about easy prompts that as a public person you can use when you're using any of the medical chatbots to feed in information, and it will be able to guide you as to what's best to do with regards to your symptoms, okay? So do not rely on AI for emergencies, diagnosis or treatment decisions, or replacing your doctor. This is really important. But AI can learn, can help you with regards to what's urgent and what's not urgent, and whether you need to see your doctor. Protect your data, don't put stuff in there. And even when you think you've deleted it, it's often not deleted, it's still there in the background. Experts will know how to get rid of it. But for you and I, if you put data that's identifiable, it stays on the system, and it could come back and be a challenge. Thank you very much. And I'm sure Linda knows what that photograph is of, yeah? So you can all come visit Doha. This is outside my first hospital in Doha. It's called The Journey of Life. It's a sculpture of the sort of fertilization process to a baby. And it's a real bronze statue, bronze thing of a full-term fetus. And it's amazing to see. Thank you very much.
Wonderful.